Welcome to you all to the Medical Grand Rounds today. I am very pleased to welcome and introduce today's speaker, Dr. Vanita Aroda. Dr. Aroda is the Director of Diabetes Clinical Research at Brigham and Women's Hospital in Boston, and Associate Professor of Medicine at Harvard Medical School. Dr. Aroda completed her training in internal medicine and endocrinology, diabetes and metabolism at University of California, San Diego. She has an interest and a very strong published record in diabetes prevention and novel therapeutics in diabetes and weight management. She also has a strong interest in understanding therapeutic interventions in large phase 3 and phase 4 clinical trials and their application and integration into clinical care. She has years of experience in conducting these clinical trials and also as a leader in these trials, served as investigator for the NIH-funded GRADE D2D and the Diabetes Prevention Program outcome studies, and as the national or international signatory principal investigator of multiple clinical trials in novel therapeutics. She's also the training director of a competitively awarded American Heart Association strategically focused research network grant. Since the beginning of the century, we know that there have been a large number of clinical trials on diabetes prevention, diabetes management, and cardiovascular outcomes in diabetes. And Dr. Aroda has been a lead investigator in many of these studies that have shaped our current understanding and being part of the management guidelines. She serves on the American Diabetes Association's Professional Practice Committee, which is responsible for updating the annual standards of medical care in diabetes. Dr. Aroda has been a role model at a time when there is a paucity of women in leadership roles in diabetes research, a fact that has been recognized by the ADA in its August publication in Diabetes. She was featured in Lancet as a role model not by accident. She stated there that while boundaries and norms may seem limiting, each of us is limitless in what we can offer. It is fitting as we come to the end of 9 days of festivities in India, and for those of Indian origin celebrating the feminine aspects of divinity. We have Dr. Aroda bring her knowledge and energy to us on this topic. On the 10th day, we do celebrate what is called as Vijayadashmi, or the Victory Day, and we hope we win the battle against diabetes. With that, I would like to invite Dr. Aroda to talk on the role of GLP-1 receptor agonists and SGLT2 inhibitors in mitigating cardiorenal metabolic risk. Dr. Aroda.
What a warm welcome. I have a little bit of goosebumps hearing the introduction. It's true, none of us end up where we are by accident. There are a lot of external forces that help shape our paths. And so I want to thank you for the kind invitation for shaping my path here to Louisville, even if it's virtually. So these are my disclosures, which I like to think represent my experience accumulated over time within the clinical trial and clinical research world. So, this is a very hot topic. And I asked Sri Prakash, I said, have you had many presentations? Because every cardiologist knows about this, every nephrologist knows about this, every diabetologist knows about this. And, he said, this is actually relatively new for us. So have at it. So I wanted to share with you my thought process and how we think about GLP-1 receptor agonists and SGLT2 inhibitors to mitigate cardiorenal metabolic risk. And I want to do that by taking you through the journey of clinical trials and what we've learned through each section. So first of all, I'll start off with the scope, then the clinical evidence, mechanistic insights, clinical guidance, and end it with, how do we actually translate this to care? So stepping back, when we look at our patients with type 2 diabetes, the risk of cardiovascular disease is quite high. This is the lifetime risk of CVD from the Framingham study, and you can see in women it's 67%, in men 78%. And look what happens as you layer in obesity. You have increased even much higher risk, so 79% in women, 87% in men if you look at lifetime risk. So it's a prevalent condition. It is what we need to focus on mitigating. And yet, when we think about cardiovascular disease and type 2 diabetes, it's not one entity we're thinking about. It's not one singular process we're trying to focus and target. There's a multitude of etiologies. Shown here are the distribution of initial presentations of cardiovascular disease. You see very high incidence of peripheral artery disease, heart failure, as well as all the traditional atherosclerotic-based diseases. So it's not just one entity we're trying to mitigate. It's not just, quote, CVD. It's a lot more than that. Now, what about CKD? Now, we've come to appreciate CKD as kind of that kind of hidden signal of sickness and of bad things potentially that can happen. So some people call the kidney the canary in the coal mine. And what you see is that CKD is prevalent in type 2 diabetes. Approximately 1/3 of adults with diabetes have CKD. A majority of end-stage renal disease is due to diabetes, about 40%. And if someone has elevated albuminuria or low EGFR, both are independent predictors of increased risk of cardiovascular disease and progression of renal disease. So we think we've gotten a better hold of some of these complications in patients with type 2 diabetes. You see the curves coming down, but as I shared yesterday during endocrine grand rounds, the number of cases of these complications, stroke, amputation, end-stage renal disease, are actually going up. And why is that? That's because of the increased prevalence of diabetes itself. Not only that, but if you look now at the most recent data from 2010 to 2015, just published in JAMA, you actually see an uptick of these complications. So whereas we thought we had a good handle of it, with the curves coming down through 2010, we see an uptick. And why do we see that uptick? The uptick is driven by the lower age group. So the 18 to 44 age group and the 45 to 64 years. So I think this is all very connected. The increased prevalence of diabetes, where we're seeing diabetes, type 2 diabetes at a younger age, and now we're seeing an uptick in the end-stage complications. Moreover, if you look at the heart disease and stroke statistics published this year by the AHA, we see that no longer is it infections, the leading cause of premature mortality. The number one cause of premature mortality or a decreased lifespan is ischemic heart disease. And if we look at the leading causes of disability, years of life lived with disability, they are, in terms of the risk factors, they are high fasting plasma glucose and high body mass index. So we are truly living in a cardiometabolic world. So to summarize this first section on the scope, the lifetime risk of CVD in patients with type 2 diabetes is high. It's higher with obesity, and it reflects a multitude of etiologies. The burden of complications, though we thought we had a handle of it, is actually increasing. And this is driven by prevalent diabetes, as well as the changing demographic of diabetes with more younger onset, as well as, impact in ethnic minority populations. We really do live in a cardiometabolic world, as shown by the most recent statistics and updates that were just published this year. And this not only affects our lifespan, but it affects really what we're trying to promote in our patients, and that's a healthy lifespan. So what about the clinical evidence for SGLT2 inhibitors and GLP-1 receptor agonists? Where did all of this hubbub begin? And so if you all recall, in 2007, there was a meta-analysis published in the New England Journal of Medicine by Stephen Nissen, suggesting an increased risk of cardiovascular disease with the thiazolidine dye and rosiglitazone. So that led to a lot of conversation, and the FDA issued its guidance for industry in 2008, asking that any new medication for treatment of diabetes be evaluated for cardiovascular safety. Now, in retrospect, this was perhaps a very serendipitous turn of events, because what we've now seen over 200,000 patients later is we have a completely new story to tell. And, we're not just thinking of diabetes in its own silo anymore, or heart disease in its own silo, or even kidney disease. So what we have here are a number of trials spanning the GLP-1 receptor agonist, any new therapy, the SGLT2 inhibitors, where the participants who took part in these trials, and I know University of Louisville has been an active site the conversation in these trials has been not just, can we see if this lowers glucose better than the other? It's been, can we see if this, which of the two arms results in fewer heart attacks? And so you can imagine it's a very different ballgame that our participants have taken part with unknown safety profiles, unknown outcomes, and yet people have committed to a very high degree of integrity. So I just want to express my appreciation there. So the first slew of studies that came out after this 2008 mandate were with the DPP4 inhibitors. And what you can see here is one after another, complete neutrality, complete safety. So that was good news that, we're not causing harm with any of the newer agents. But, there was a lot of like, oh my goodness, how did we just spend so much of our time and resources just to find out what we probably knew already, that these are truly safe agents? And then came EMPA-REG. So this was 2015. It was presented at the European Association for Study of Diabetes, and I happened to be fortunate to be in the audience. And just to set the stage for EMPA-REG, the question here was, what are the effects of this novel medication, empagliflozin, an SGLT2 inhibitor, compared to placebo on top of standard of care on major cardiovascular events in patients with type 2 diabetes at high risk? So the patient population here was patients with type 2 diabetes with established history of cardiovascular disease, also with an elevated A1C, suggesting a need for further glucose treatment intensification. They're randomized to empagliflozin 10 milligrams or 25 milligrams or placebo on top of standard of care with over 7,000 participants. Again, a completely new ballpark compared to previous glycemic efficacy studies. This was conducted in 2010 to 2015, again, following the FDA mandate with a follow-up time of 3.1 years. And what we all saw in the audience was, what we all experienced was this big gasp of, oh my goodness, does it actually matter how we treat type 2 diabetes? Because now what you see a 14% reduction in overall major adverse cardiovascular events. You see a 38% reduction in death from cardiovascular causes in a very high-risk population. Not only that, but a 32% reduction in death from any cause. And kind of the surprise was, this new outcome of hospitalization for heart failure, a 35% reduction. The other thing that was a surprise is if you look at the separation of the curves, this wasn't your typical modifying atherosclerotic cardiovascular disease years later. You see an immediate separation of the curves within the first 3 months, whereby people on the SGLT2 inhibitor demonstrated that they did better in all of these cardiovascular events compared to the current best standard of care. So then a year later, LEADER came. So this was looking at liraglutide and the cardiovascular outcomes in type 2 diabetes. And this was presented live at the ADA. And some of you may have been there, but if you recall, it was actually 6,000 people waiting right outside the doors of the auditorium to go, rush in like a rock concert to find out, would this be the same? It was a lot of excitement. And fast forward, now we have an embarrassment of riches of one positive study after another. So here the question is, what are the long-term effects of the GLP-1 receptor agonist, liraglutide, on cardiovascular outcomes when added on top of standard of care? Now here you see a majority of the participants did have established cardiovascular disease, about 70%, but they also included participants who did not yet have established cardiovascular disease, but who had higher risk of cardiovascular disease, such as microalbuminuria, proteinuria, hypertension, LVH, or a low ankle brachial index. They're randomized to liraglutide daily injectable GLP-1, 1.8 milligrams a day versus placebo, over 9,000 participants with a follow-up of over 3.8 years during the same exact time period of study as the EMPA-REG study. Here, what you see, very outcomes, very similar. Someone's not on mute. Okay. 13% of the primary outcome of 3-point MACE. So a cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, as well as a reduction in death from cardiovascular causes of 22%, and a non-significant reduction in the hazard ratio for non-fatal myocardial infarction. Now, what was interesting here is because of the two different subgroups, they're able to see whether there might be a difference. And here you see that the definite proof was in those with established cardiovascular disease, but there was a significant p-value for interaction in between the two subgroups. So there wasn't a consistent signal in those who just had multiple risk factors. Moreover, you see that in those with renal function, those who had significantly worse renal function and eGFR less than 60 stood to gain the most, and that there was a p-value for interaction. So here we saw that the GLP-1 receptor agonists seem to truly benefit those who are at the highest risk. Now this is, again, these were live results where the purpose of these studies was to demonstrate safety, and now we have these major significant positive findings. I use this image that Joe Verbalis at Georgetown would always use when he would talk about translational research from bench to bedside, but it is also from bedside to bench. So here are the clues that we had as a field. We have similar primary outcome results between the SGLT2 and the GLP-1 receptor agonists. We have differences, and if I go back one, you can see the separation of the curves here are different than what we saw for the SGLT2 inhibitor. Here we start seeing a separation of curves more about 12 months later, so a bit more of the modulating atherosclerotic disease process as opposed to what we saw with SGLT2 inhibitors. We see also slight differences in the profiles between the two in terms of the cardiovascular outcomes. We see, reductions in cardiovascular death, but more of a signal for a reduction in stroke with the GLP-1 receptor agonist, and a definite strong signal for reduction for heart failure with the SGLT2 inhibitor. Mediation analyses were performed for both EMPA-REG and for LEADER, and also gave us different clues that, with the GLP-1 receptor agonist, there's a strong tracking of A1C and albuminuria in terms of explaining the effects or something associated with those two factors. Whereas with the SGLT2 inhibitor, the mediation analyses borne out changes in hemoglobin and hematocrit as tracking with the benefits seen, or something that would track with hemoglobin and hematocrit. So now, fast forward to 2021, there are a number of very consistent studies in both areas. I'm highlighting them for you here. Just published this year by Naveed Sattar in Lancet Diabetes and Endocrinology. We have a very consistent picture with the GLP-1 receptor agonists, 14% reduction in major adverse cardiovascular events, 13% reduction in cardiovascular death, 10% reduction in myocardial infarction, and a 17% reduction in stroke. In terms of all-cause mortality, again, 12% reduction in mortality. And this is, now starting to declare itself over time. We're starting to see perhaps a signal for possible admission for heart failure, about 11% reduction, but not as strong as with the SGLT2 inhibitors. And the thinking here is that when you reduce cardiovascular disease, atherosclerotic cardiovascular disease, ultimately you will impact heart failure. So again, a slightly different mechanism and pathway towards this. We've also seen decrease in the composite kidney outcomes, including albuminuria, 21%, and decrease in kidney function, again, by meta-analyses. Now shift to the SGLT2 inhibitors. This is from Darren McGuire putting all the trials together, and you see some similarities and some differences. So 10% reduction in major adverse cardiovascular events, 15% reduction in cardiovascular death, 9% reduction in MI, and a very, very consistent, if you look at the plots, very consistent within the class reduction in hospitalization for heart failure of 38%. But unlike the GLP-1 receptor agonist, no major effect on stroke. So brief comment on stroke. So this is an exploratory analysis published from the REWIND trial looking at dulaglutide on stroke. And here you see a marked reduction in the risk of stroke with the GLP-1 receptor agonist dulaglutide. And they characterize it even further. And if you look at it, the main difference was in non-fatal stroke as opposed to fatal stroke, and a significant reduction, a 26% reduction in disabling stroke. And if you looked at the type of stroke, it was really a reduction in ischemic stroke. So 25% reduction in ischemic stroke. Again, consistent with an atherosclerotic mechanism of action. In an editorial, I put it all together that if you look at it over time, this has just been kind of an emerging signal that is just much more consistent now. We saw both a reduction in stroke with the dulaglutide in REWIND as well as semaglutide in SUSTAIN 6 as a secondary outcome. And meta-analyses now give a very consistent reduction in total stroke and non-fatal stroke. So putting this together, when we think about our patients, we have a very limited number of therapies and a significant disability associated with stroke. So that, again, clues you into the potential role and value of the GLP-1 receptor agonist for preventing atherosclerotic cardiovascular disease such as stroke. Now, what about renal outcomes in type 2 diabetes? Now, this has been also very interesting because what you see here is even though everything's going in the right direction, you have a much stronger effect of the SGLT2 inhibitors in terms of a magnitude effect on renal outcomes. And this, again, emerged from the cardiovascular outcomes trials where we see a 38% reduction in the secondary renal outcomes with the SGLT2 inhibitors. And then on the right side, when you exclude macroalbuminuria, your main benefit really is with the SGLT2 inhibitors. So a lot of people think that the reductions and improvements in kidney outcomes with the GLP-1 receptor agonists, as reflected by macroalbuminuria, is itself showing that you're improving inflammation and, again, the atherosclerotic process. So putting this together, what has the clinical evidence shown us from over 200 multiple trials? We see a commonality between the two classes in reducing overall major adverse cardiovascular events, MI, death, and broad renal endpoints, but the two classes kind of emerging with their own unique thumbprints, with the SGLT2 inhibitors having a cardiorenal axis in terms of improving risk for hospitalization for heart failure and primary renal outcomes, and the GLP-1 receptor agonist having its own thumbprint on more ischemic diseases such as stroke. Now, what can we learn from the clinical trials on potential physiologic mechanistic insights? And I've already clued you in on that from the clinical evidence, but let's take a look even deeper. So this is a model that I really like, published by Peter Libby and Jorge Pletsky early in 2002, where they describe a variety of risk factors converging on the artery to promote atherogenesis in individuals with type 2 diabetes. And updated this year in a Nature publication by Peter Libby, really highlighting inflammation as a link between dyslipidemia, obesity, and other risk factors to cardiovascular disease. So what I'll share with you is, I think in this next session, I really do think that GLP-1 receptor agonists fit this more traditional atherosclerotic model in terms of how they act. So now let's take a step back, and before diving into some of that data, revisit what the GLP-1 receptor agonists are and, the history of the incretin concept. So if we go back, all of this work, goes back over a century, where it was first recognized that a gut hormone may stimulate the endocrine pancreas back in 1905. The word incretin, which means from the Latin to increase, was coined in 1932. A glucose-dependent incretin mechanism of action was showed in the 1960s, and GIP and then GLP as an incretin in the 70s and 80s. But University of Louisville had its own major imprint on the history of what we understand about the incretin concept and GLP-1 receptor agonists through understanding that there was actually gut glucagon-like immunoreactivity. So your very own Ellis Simols, again, this well predated my exposure, so it was very fascinating for me to learn about this. This is just published, a summary of the full incretin journey was published in Cell this year by Stephen O'Reilly. But as you can see, credit is given to Ellis Simols and Vincent Marks in 1966 for identifying glucagon-like immunoreactivity that was present in extrapancreatic tissues. And what they also specifically noted is that in pancreatectomized humans, there was still glucagon-like immunoreactivity, suggesting that the source of this glucagon-like immunoreactivity was not the pancreas, and sure enough, later on, it was isolated to be in the gut. So a major University of Louisville impact on the field that is now spanning over a century. So now back to the clinical data in terms of the role of GLP-1 receptor agonists. Meta-analysis published in the Annals of this last year really highlights that the GLP-1 receptor agonists are of the highest efficacy treatment classes for treatment of diabetes. Here you see semaglutide, liraglutide, dulaglutide, all up towards the top, on par or if not even better in some of the head-to-head studies with insulin itself. On the right, you see similar findings in patients receiving metformin-based background therapy. So targeting, again, this one major aspect of the ASCVD pathway, and that's hyperglycemia. I want to highlight a publication just published this last month in Diabetes Care, which again kind of brings to surface the role of glucose itself in ASCVD risk. And I think sometimes glucose is not sexy enough to talk about, but I want to reiterate how important it is to never forget it. So this is from the DCCT trial, the Diabetes Control and Complications trial in type 1 diabetes, which I think gives us a purer model of the effects of glucose over time. What you see in the bottom row is that the lowest risk of cumulative cardiovascular disease incidence is in those who achieve control early within the first 10 years and maintain control in the outer years, 11 to 20 years. So if you're at 7% and 7% on average, that's the lowest overall 20-year cumulative incidence of cardiovascular disease. But what I think is even more interesting is if you look at the second and third rows, these are two populations modeled from the DCCT where the overall A1C or glycemic control was about the same, was exactly the same over 20 years. And yet whether you get to go early versus later translates into lower risk of cardiovascular disease, a 33% reduction, and a lower risk of the reduced eGFR. So it's not just about achieving goal, but getting to goal early and hopefully staying at goal. So next is, what about the effects on body weight and obesity? Here too, another full meta-analysis, which we've seen time and time again in all of the head-to-head studies. GLP-1 receptor agonists have a unique mechanism of action and not only helping to normalize blood sugars, but reducing appetite centrally, such that patients feel fuller faster, they consume fewer calories, and some of the mechanistic studies show a reduction particularly of high-fat calorie intake. And here you see that with the newer GLP-1 receptor agonists, you kind of have a separation from the previous generations, where we're starting to see greater and greater weight reductions with the more novel GLP-1 receptor agonists. So what might you ask, how might this impact cardiovascular disease? The Look Ahead study looked in patients with type 2 diabetes who are at high risk of cardiovascular disease over 11 years to try to see whether intensive lifestyle education could make a difference in cardiovascular outcomes. And even though the primary outcome of the study was negative, a post hoc analysis showed that in those who lost a higher magnitude of weight loss of at least 10% within that first year, the risk of composite cardiovascular outcomes was significantly reduced by 21% over the 10 years. So again, I think we sometimes under-recognize the role or impact of hyperglycemia and obesity. Now, I'll share with you one of the studies that I was a lead investigator for. This was the SUSTAIN-4 trial in looking at subcutaneous semaglutide once a week versus basal insulin as a head-to-head active comparator study in patients with type 2 diabetes. And this was a randomized open-label trial. And what you see in the top, greater glycemic reductions with semaglutide compared to even treat-to-target approaches with insulin glargine. And what you see here in the bottom, with the semaglutide, the red and the blue, pre and post self-measured plasma glucose over the full 24 hours at marked points, you see that the semaglutide does a better job at reducing glucose at multiple time points throughout the day. So it's not a unidimensional approach to diabetes. It's by targeting the GLP-1 receptor, by improving glucagon normalization, by improving insulin secretion, by improving appetite, you're having a multimodality addressing of the underlying physiology, such that there was then also a greater weight loss as well. But what was published in the appendix of this paper, not only was there an improvement in hyperglycemia and obesity, but we also looked at some of the cardiovascular risk markers. Now, this is not a CVOT population. This is your very typical bread and butter treating diabetes patient population. And what did we find? We saw a significant reduction compared to basal insulin of high sensitivity C-reactive protein compared to baseline and compared to insulin glargine, and a significant reduction in a thrombotic marker, plasminogen activator inhibitor. Not only that, but we saw improvements, again, buried in the appendix, in all of the lipid parameters compared to insulin glargine. And this has been borne out in multiple other of the semaglutide studies compared to other active comparators. Here we see, I was also a lead investigator for the oral semaglutide program for the Pioneer 1 study, where same thing, buried in the appendix, not only was there good reductions in glycemia, good reductions in weight, but we see a significant reduction in C-reactive protein compared to baseline and compared to placebo. And uniquely, compared to even the SGLT2 inhibitor, you have a reduction in C-reactive protein with the GLP-1 receptor agonist versus the SGLT2 inhibitor. So here we see a very consistent mechanism of action approaching the atherosclerotic pathway through these multiple dimensions. Now, going back from the clinical data to the bedside, we've also seen data in preclinical models supporting this hypothesis that GLP-1 receptor agonists really do have an anti-atherosclerotic mechanism. Here you see the ApoE knockout mice and LDL receptor knockout mice treated with GLP-1 receptor agonist, liraglutide or semaglutide, having reduction in plaque, reduction in body weight, reduction in inflammatory markers and lipids, and independent of even independent of the body weight, as well as a direct reduction in the transcriptomics in the aortic plaque tissue. Now, what about SGLT2 inhibitors? What's emerged here, again, it's the bedside back to the bench of people trying to figure out, why is there an immediate separation of the curves? Why is there a prominent effect on hospitalization for heart failure? And what's emerged has been a story more of impact perhaps on LVH, perhaps on myocardial energetics, where what you see is hearts treated with empagliflozin, you have increased cardiac energy production relative to untreated diabetic hearts. And you see a lot of other direct and indirect effects on the heart, which really support its role in reducing heart failure. Moreover, in the kidney, what we see is a direct impact on hemodynamics. Here on the left is a model of the diabetic nephron, where you have increased sodium and glucose reabsorption within the proximal segment via the SGLT2 receptor, and therefore you have decreased distal delivery to the distal tubules, and then you get reduced feedback and therefore increased JG pressure within the glomerulus. And so there's a very clear hemodynamic relationship, whereas when you then inhibit the SGLT2 receptor, you have more delivery of sodium and glucose to the distal segments, and then you have increased feedback from the macula densa, resulting in overall decreased juxtaglomerular pressure. So there really, within the kidney, appears to be a model more, again, of affecting the hemodynamics. And now we're starting to recognize and realize that there really is a cardiorenal axis. And if you talk to the nephrologists, a lot of them will say that the impact of poor kidney function on poor cardiovascular disease outcomes is probably mediated primarily through LVH and the like. So a unique and distinct set of mechanisms of actions compared to what we've seen with the GLP-1 receptor agonists. Now, the CVOTs gave a signal for potential effects on the kidneys, But it wasn't until the Credence trial came out, which looked at primary renal outcomes in the high-risk patient population, that we appreciated that, these really are nephroprotective agents. So Credence looked at patients with type 2 diabetes with albuminuria kidney disease, so albuminuria of over 300 milligrams per gram creatinine, and already treated with RAS blockade. And what was found, again, that ooh-ah moment of, oh my goodness, how we treat diabetes can actually impact what happens with the kidneys. So here's the primary composite outcome is end-stage kidney disease, doubling of the serum creatinine level, renal or cardiovascular death, where we see a 30% reduction. And very consistent profile, no matter how you sliced or diced it, amongst all the renal specific outcomes. So the renal specific outcomes shown here on the right. Following that was the DAPA-CKD, which showed similar results, but now in both patients with or without type 2 diabetes. So now we're getting a much more consistent picture of effects of SGLT2 inhibitors directly on the kidney, whether or not you have diabetes. Moving forward, then there was the DAPA heart failure study, which looked at the primary outcome, now different from the MACE outcomes, of primary outcome of worsening heart failure or CV death. And unique here again, it was in patients with or without type 2 diabetes. Here you see a significant 26% reduction in the primary outcome of worsening heart failure or cardiovascular death, focused really strong effect on hospitalization for heart failure. And if you look at the bottom, no difference whatsoever whether or not they had type 2 diabetes at baseline. So this has been a very rapidly evolving field where we're having these large trials, large data, seminal results, e-published September 2019, hard published in New England Journal of Medicine in November 2019, and already an FDA updated indication a month prior in October. This is how rapid the evidence is changing the guidelines and what we do. So the big question then in the heart failure community is, wow, the SGLT2 inhibitors really do seem like heart failure drugs. They should be one of the core pillars of guideline-directed management. But is it only in those with reduced ejection fraction? And so just this last month, published in New England Journal of Medicine, is the empagliflozin in heart failure with preserved ejection fraction. So this is, again, independent of whether or not they have diabetes. Diabetes is not a factor anymore in some of these studies. So it looked at patients with class 2 to 4 heart failure who had an ejection fraction of over 40%, randomized to empagliflozin 10 milligrams versus placebo. And here again, a very consistent early separation once more with a hazard ratio showing a reduction of 21% in the primary outcome. And a marked reduction again in hospitalization for heart failure with no difference whatsoever whether or not they had diabetes at baseline. So I really like George Bacris's quote. This is from one of his commentary publications, that the totality of the data would suggest that SGLT2 inhibitors are cardiorenal risk-reducing agents that have glucose lowering as a side effect. Now, as an endocrinologist, I take a little bit of issue with the glucose lowering as a side effect, but I think we all get the point that these are nephroprotective agents, cardioprotective agents, as well as having glucose lowering, though not as strong as some of the other agents. And if you see here, this is how impactful these types of studies have been in the field. If you look over time at the different types of kidney trials in terms of trying to show benefit, what you see here with Credence is a marked improvement compared to some of the historical studies. So to summarize this portion, if we take a look at SGLT2 inhibitors and GLP-1 receptor agonists, I think if we look at the totality of the data with a lot of the ongoing studies and mechanistic studies still happening, they appear to have complementary, distinct mechanisms and physiologic benefits towards mitigating cardiorenal metabolic risk. And what it looks like is that the GLP-1 receptor agonists have more anti-atherosclerotic, anti-inflammatory modes of action, addressing those traditional cardiovascular pathways. And SGLT2 inhibitors appear to be addressing more myocardial energetics and the cardiorenal axis. So now that we've gone through all of the evidence, the bench to bedside, bedside back to bench, what have our guidelines told us about this? How have the guidelines, assimilated all of this? So I'm going to talk you through. This is the very first ADA recommendation that was published in 2009 by David Nathan et al. And you see, life was very simple not that long ago. It was lifestyle and metformin. Okay, if they needed intensification, maybe insulin, maybe sulfonylurea, less well-validated therapies. The GLP-1 receptor agonists were just emerging on the scene. Pioglitazone was recognized for its other potential cardiovascular effects. But one thing has stayed the same, and that is the idea that it really is important to help our patients achieve glycemic control. So check the A1C every 3 months until the A1C is less than 7%. Now what do we have? Based on all of these trials, a major rework happened in 2018 when the ADA and EASD got together and formed an international consensus of how do we reconcile all of this new data, all of this novel data. And the ADA itself meets every year and publishes its standard updates every January as a supplement in diabetes care. So it's been a privilege to be a part of that process. What I want to do is I want to take you through that. It's not as simple anymore, and yet what the trials have done is it has shown that we really need to think about the patient in front of us, what their long-term risks are, what their comorbidities are, and tailor or match the therapy to those outcomes. And let me walk you through this step by step, starting with the upper right. So the core fundamental stays the same, that we need to avoid therapeutic inertia. Even though we're all getting caught by the waves and the CVOTs, glycemic control is still important, and we've learned a lot of lessons as to how and why that is. So from our fundamental, UKPDS foundational study, we know that lower improvements in glycemia, lower glycemia is associated with a decreased risk of everything, and that glycemia hands its head in no matter what study you look at. But we've come to recognize from studies like the Accord, et cetera, that it's not just about getting glucose low, but it's about getting there safely. Now, on initial therapy, so first-line therapy has always been lifestyle and metformin, but if you look at the text within the ADA standards of care, just in this last year, you'll see that it talks about additional or alternative agents may be considered in special circumstances, such as in individuals with established or increased cardiovascular or renal complications. And so think about the patient scenario who a patient, in their 60s has a history of heart disease and a stent, and then they develop type 2 diabetes. That's a very common scenario, especially because the cardiologists are often diagnosing diabetes. It's not that you have to wait and put lifestyle and wait for them to see whether or not they can get to goal with metformin. We know that these are cardioprotective and renal protective agents in the right population. On the right, what you see is a meta-analysis looking at whether or not there is a difference in the outcomes of these major CVOTs based on whether or not they were on metformin or not on metformin. And as you can see, as a whole, there was really no major difference. So this is an area that I think we are kind of living the paradigm shift as we speak. Now, in the left column, consider independently of baseline A1C. So it's not about glycemia anymore in this left side of the graph. Independently of their A1C target or independently of metformin use, again, based on the studies, whether or not they should be on an SGLT2 inhibitor, a GLP-1 receptor agonist, or even both. So one area I want to comment on, the data has been very consistent in those with established cardiovascular disease. But what about people who are at high risk who have not had yet their first event? So, what do we do about those populations? And the ADA gives examples of, considering these agents in those who have high risk, meaning they have evidence of stenosis over 50% or LVH. The ACC characterizes their high-risk population as those with end organ damage or with multiple risk factors. It could be age, hypertension, smoking, dyslipidemia. It's a little bit more generous in their recommendations. But we do have, I believe, 2 studies that help us kind of consider the primary prevention population a little bit better. The REWIND study with dulaglutide as a GLP-1 receptor agonist and the DECLARE study with dapagliflozin. unlike the earlier CVOTs, these had a much broader patient population with a higher percentage of people kind of fitting more the primary prevention group with a longer term follow-up, 5.4 years and 4.2 years. And what did we see? Here with dulaglutide, with Rewind, you see, again, a significant reduction in the primary outcome as a whole, but no difference whatsoever between the primary prevention population and those with established cardiovascular disease. Again, a study that was designed and powered enough to be able to better address that question. And then in the DECLARE study with dapagliflozin, again, a very high primary prevention population, I think probably the most generalizable of all the CVOTs, where there was a significant reduction in the primary outcome, but no difference whatsoever between those with established cardiovascular disease and multiple risk factors. So there I think we have our clues. And this study, for me, analysis of the DECLARE kind of seals the deal. This is done by David Berg et al. At the TIMI at Brigham, where they categorize the broad spread of the patient population in DECLARE to very high risk all the way to low risk. And what you see here is that there's a decrease in the absolute risk reduction as you get to the lower risk populations, kind of like what you would see with statins, but a very consistent relative risk reduction across all risk populations. Now, because of the lower absolute risk reduction, you have a higher number needed to treat. So I think this puts it in context that yes, we definitely still see benefit even at the lower risk, though because their absolute risk is lower or their baseline risk is lower, the absolute risk reduction might be less. Now, what about with CKD? Based on the data that I presented, we see that there's a preference for SGLT2 inhibitors in patients with DKD and albuminuria, and then for people who need treatment intensification to ensure, again, choose the alternative class, the GLP-1 receptor agonist. So to bring this all together, I think I don't want us to forget glucose control. That's still at the basic foundation. I don't want us to forget about obesity and weight management. Again, is at the foundation. But among patients with type 2 diabetes and established or high risk of heart disease, established kidney disease, heart failure, we do need to include evidence-supported cardiorenal protective agents within the regimen. And this is an A-level recommendation or within the standards of care. So how are we doing as a society? Let's give it some perspective. This was just published this year from Adam Nelson and colleagues looking at over 150,000 patients from a medical claims database who had type 2 diabetes and established cardiovascular disease. So there's no doubt whatsoever that they should be on at least either an SGLT2 inhibitor or a GLP-1 receptor agonist. And less than 10% were on either one of these therapies. So even, despite the oohs and ahs that we've all experienced when we've seen the publications or have seen the results presented, we do need to think about how to better incorporate these within the cardioprotective regimen. So they conclude with the call to action, not only just to one segment of society, but to all of us, patients, providers, industry, regulators, societies, and payers to help close these gaps in care, because the first time in a very long time we have agents that can help truly mitigate risk. So to bring this to a close, I just want to end with, how do we translate the evidence to our own day-to-day practice? And, this is, I think, we don't share enough what we do within the clinical trial realm, and I think that we should, because the clinical trial realm really is our dress rehearsal for how things will be in the real world. And what I like to focus on in terms of educating participants and educating patients is what's going on in their bodies. So number one, patient-centered physiology. We know that diabetes increases the risk of heart and kidney disease. We know that better controlled diabetes and all the risk factors may lower the risk. I look at patient-centered goals, that our goals are not just all about that A1C, but they are multifold, and that specific medications can help improve their overall risk in the long run. And then making sure that they are set up for success. How do we incorporate these medications based on a background of a lot of other complex therapies? Do we need to adjust any medications? How do we make sure that they tolerate these medications? Explain the mechanism of action, explain kind of the signals to look for, make sure you elevate patients in that process. So between yesterday and today, endocrine grand rounds and medicine grand rounds, I hope I've shared a complete picture that, all of our disciplines and fields, we really are looking at the patient with cardiometabolic risk across the lifetime of continuum. And it's really exciting to see how, trials impact guidelines and how it ultimately impacts care. And so with that, I want to just round out the last 2 days and say thank you for such your warm hospitality, even though it's virtually. I started off the day yesterday meeting with the endocrine fellows where I shared with them 5 research pragmatic gifts. How did you develop in 3 minutes or less your own individual development plan on a page? How do you frame your own research question? Where we workshopped each other's research questions, and I hope that they really came away with the sense of this gift. I try to give them the safe space playground to do so. We then, in the afternoon, with the endocrine audience, focused on diabetes prevention or delay and the implications of that, and are ending today with the full cardiometabolic spectrum. So thank you, and I hope to come see the famous Louisville slugger in person.
I just want to say it was wonderful and admire your knowledge and understanding of the topic. Thank you for this.
Thank you for that comment.
Thank you, Dr. Aroda, and Dr. Mokshagundam. If you had a question, there are a couple of questions in the chat area. But I don't know if you had a question to start off, Dr. Mokshagundam.
First of all, thank you very much for the 2 days. We have really enjoyed the talks and also one-on-one talks with you. Basically, the field has grown over the last few years and really requires a collaborative effort to reduce cardiometabolic risk. So one of the questions that I had, I think someone else had also had, is about the effects of combining the SGLT2s and GLP-1s. Are there any studies that are ongoing to evaluate that?
It's a great question. I will say that's the $1 million question, but instead I'm going to say that's the $30 million question, because PCORI, the Patient-Centered Outcome Research Institute, just funded a large 30 million randomized control pragmatic trial to address that. Brendan Everett at the Brigham is the awardee of that. So that will be the longitudinal study. But in the absence of that, if you look at sub-analyses of the major CVOTs, if you look at the database analyses, what we see again is a very consistent picture that even on top of background SGLT2 inhibitors, as GLP-1 receptor agonists have additive effects and vice versa. So there is very strong database evidence, subgroup evidence, and real-world evidence to support the combination.
Maybe you can answer, Dr. Mokshagundam can answer, how do a cardiologist coordinate these patients with the diabetologist or primary care physician?
So I'll share a little bit of insight. I'm involved in one of the implementation trials called the Coordinate D, and that's coordinated out of Duke. And what we see is when the cardiologist can focus on, using these agents for cardiometabolic risk reduction as the primary goal and not, glucose reduction, they tend to, do better. But what you need to think about in terms of when to reach out to the endocrinologist is if they are on insulin or if they're on sulfonylurea, because that's where, those are the two groups of agents where let's make sure that the endocrinologist or the person managing the diabetes can give guidance on how to reduce those agents. Sri Prakash, what do you think?
Yeah, I agree with it. The problem that we have is there are not enough endocrinologists, so you can't refer to too many patients. But the higher risk of hypoglycemia, those are the ones. And also, if you have patients who have uncontrolled diabetes, that means you're giving them GLP-1 or SGLT2 inhibitor, but the A1C is still high. We have again pointed out that glycemic control is still important. So they may need something else on top of what they're getting. So that would require additional help from the endocrinologist. So I think having open lines of communication is what is most important, and trying to reach out. I think increasingly trying to do, e-consult type of things would help. So I think that's where the things are moving in that direction.
Yeah, as you saw, some of these agents have been shown to be effective whether or not they have type 2 diabetes. It's really just a matter of safety because they have glucose lowering that you want to make sure to lower the dose as needed of those agents that can cause hypoglycemia. Great question.
Okay, and Dr. Aroda, we have about 3 questions in our chat area. The first comes from Dr. Dinesh Kalra, who is actually our new Chief of Cardiovascular Medicine, and his question is, and I read these verbatim. I read them as they're typed. So he asks, given that it is unlikely that there will be head-to-head trials between these agents anytime soon, do you think the CV benefits are a class effect, or are there meaningful differences between the 4 available SGLT2 inhibitors?
So, with the Virtus study that was published last year showing, not the same benefits, everyone's been scratching their head. In general, the SGLT2 class seems to have been pretty consistent in their effects, but, I can't say more than that. I think there's been more similarities within the SGLT2 inhibitor class as opposed to the GLP-1 receptor agonist class, where there are marked differences between some of the agents.
Okay, first of all, I want to thank you so much for such an excellent talk. I was actually intrigued by the data on amputations and progression or worsening of peripheral arterial disease with some of these agents. And so that's what makes us wonder if there's one particular agent we reach for. And I think at the moment we prefer EMPA or DAPA for both heart failure and for CAD or ASCVD. So I just wondered if you had a preference of agent.
Yeah, no, that's a great question. In my clinic, I try to give credit to where the studies were appropriately designed to do so. So I go, this fits more the credence population. This fits more the DAPA CKD. But to your point, with canagliflozin, there was an increased risk of amputations. But later on, the FDA removed that black box because it was not seen in the follow-up studies. And part of what we believe is that, during the study where the signal was indicated, the letters were issued to the trial investigators, they were issued to the participants. So we all just got better at looking at feet. And so I actually think that was a big part of it, is just, paying attention. Now, if someone has an infected ulcer or a gangrenous foot, I would definitely have hesitation. That's not the right time or place to introduce one of these agents.
Sure. I do have one more question. So there's a prevalence, and we've called this twin epidemic in our South Asian guideline paper on both diabetes and obesity, especially in countries like India and Pakistan, where it's just blowing out of proportion. And so I have 2 questions for you, actually. One, do you think there is a substantial yet undefined genetic predisposition aside from their lack of activity and visceral adiposopathy that you see in these people that is accounting for that? And 2, you showed some very provocative, good data from DECLARE and from REWIND. Should we be using these agents prophylactically along with a statin as cardiologists? Like, we give statins to every diabetic, but maybe we should be adding these agents also on top of that if cost is not a factor?
Yeah, it's such an excellent question. And this is where, I have to be careful to be fully balanced. I think the story we're seeing here is similar to the statin story. We're never going to have the 50-year study that blows the entire NIH budget to see whether earlier introduction will make a difference. And yet, very consistently, what we see, I think it's this model of pack years, of minimizing that risk exposure over the longest period of time does make a difference. So, we tailor it to the individual, and my sense is that we should be considering these very early in the spectrum. To your point on South Asians, a truly important question. I think what we use clinically doesn't get to the heart of the matter with South Asians. There's higher Lp(a) abnormalities, there are higher abnormalities. You could tell this more to me in terms of, LDL particle number and all the things that we really don't assess clinically. So is there a better role for earlier screening, like with coronary artery calcification? I think that these will make a big difference. Earlier screening, early objective data.
Absolutely. Thank you.
All right, Dr. Rodo, a couple more, and I think you may have already asked this or may have answered this. This is from another one of our cardiologists, Dr. Shahab Gafghazi. He asked, how about combining the two classes?
I think it makes a lot of sense. Again, from mechanism of action, from clinical profile, they're completely distinct. I think when we're dealing with cardiovascular disease, it's not one disease, it's atherosclerotic, it's heart failure, it's LVH, it's dysfunction. I think they are non-overlapping and comparable. So I would be in favor of that for the purpose of cardiometabolic risk reduction.
All right,
and I think that's where the field is moving.
And
well.
this is a long one. It's from Dr. Levinson, who's one of our researchers, and he would like to know. As I said, I read them as they're typed. The problem, as I see it, is that the absolute risk reduction is very small, which indicates poor treatment accuracy. There are significant differences because thousands of patients are studied very large N. In this case, the so-called baseline risk is poorly defined. For example, in the dapagliflozin study of heart failure, those with type 2 heart failure showed an NNT of 15, of 13 to 26, but those with type 2 and type 3 heart failure showed an NNT of 52. So he points out my calculation, with a CI of minus 41 harm to 15 benefit. Thus, treating all persons with HF with these drugs may not be appropriate. Clinicians need to be very selective in examining these studies and who they treat. Could you comment on this question?
What a great comment, Dr. Levinson. And I just want to say thank you, because I think what I've done here is I'm encouraging all of us to talk together about this. I think we need to get better, again, at clinical risk factor identification. And I would allude you to another paper, again, by David Berg, published just this last month in Diabetes Care, looking at NT-proBNP and high sensitivity troponin T to help characterize the risk factors for the wide declared population. And what they found is even in that intermediate risk category, characterized by biomarkers, that you do see benefit. So I think this goes to the earlier point of how do we identify the people who would stand to benefit? But I think your points are very well taken.
Vanita, this is Satya Krishnasamy, one of the endocrine faculty and fellowship program director. Thank you for the wonderful review. And we are happy that we were part of several of those studies, mostly at the VA site here, starting with LEADER all the way to the ongoing study with the oral semaglutide agents on obesity and CVOT trials. So my question was this. And I was at the audience at the ADA when you gave your wonderful presentation at LEADER, among the 6,000 audience. So, and that was a terrific presentation at that time too. So, is the cost. So we struggle with this day to day. Yes, we know, and we were part of the studies. I was the PI on several of these studies here. So, is the cost. We struggle with that all the time, whether it's patients in their 30s, 40s, working poor versus Medicare. We do struggle with, how do you make sense of how do you, cover these, is there any sort of, just like the insulin solutions, is there any future to this light at the end of the tunnel?
Yeah, I think, thank you so much for the comments. I think by our partnership with the cardiologist, it's actually a good thing, because, when there is interdisciplinary partnership and the evidence is so obvious, then you actually have greater ammunition to deal with the regulators and, the people who control what can happen. So I think this is a bigger conversation. I think change is happening with professional societies, them looking at the guidelines and making the evidence. But I agree with you that cost is always going to be an important factor. We have to factor cost in at the individual level. But the people who are controlling the cost, there are now mechanisms of actions to advocate and support patients getting the best therapy. But again, an important issue and an ongoing conversation.
All right, Dr. Aroda, I know you're on a bit of a tight schedule here. One more quick question. This is also from Dr. Gavgazi from Cardiology. He wants to know if there are any studies that are looking at any potential benefit of GLP-1.
So there, in terms of novel areas, there.
Hey, yeah, I'm sorry. So I guess maybe the question didn't come across accurately. This is Dr. Gapaz. I was wondering if GLP-1 is being studied in patients with coronary disease and no diabetes, because we're now
Yeah.
like maybe we should just go that way.
So, that's the final circle on my last slide was obesity. So the SELECT trial is looking at semaglutide in patients with obesity and a history of established cardiovascular disease. It finished enrolling 17,609 individuals. So we will get those results in probably 2024 is when it's expected to complete. But that's going to be again, an important question of, independent of diabetes, should we be treating earlier?
All right, Dr. Aroda, thank you so much. Dr. Mokshagundam, if you'd like to wrap up.
Thank you very much, Dr. Aroda. I know we could keep talking about this forever, but we have to come to a conclusion here for today's Grand Rounds. Thank you very much for the 2 days. We have really enjoyed the lectures, and also our fellows have enjoyed your talk with them. So thank you, and hopefully we'll have you over here sometime later, and certainly we'll meet you in one of the conferences again.
Thank you.
All right, Dr. Aroda, thank you so much. And I just want to, just real quick, and I think it was, they mentioned that it was mentioned yesterday, but we have a tradition of a gift for our guest speakers that is very Louisville-centric. So I have one right here that you will probably, we will be sending you a Louisville Slugger bat commemorating your Grand Rounds visit here with us and yesterday and today. And we really appreciate it. I know the endocrinology group and appreciates everything with the faculty and the fellows and our group, the full group. This is a great talk, and we really do appreciate it.
Oh, I love it. Oh, see my blank walls? It's going to go there.
Awesome. All right.
Thank you.
Okay. Thank you.
Bye-bye.